Welcome to our course of counseling psychology or psychological counseling. We are at Climb. Climb is Christian Leadership Institute of Minnesota and beyond, Kitengela campus. We are situated right behind GK Prison Kitengela at Airview Place. When you come to Airview, you ask where the former Airview Educational School, the primary school was, and that is where we are located, in a church called Jesus the Springs of Healing Sanctuary. And I'm your teacher, Patrick Marindani, and welcome to our today's course. We are going to look or to study the psychological disorders. And I would like us to, first of all, let's begin by saying what we said last time, that psychology comes from the word psych, and psych is all about the mind. And psychological disorders, also referred to as mental disorders, are abnormalities of the mind that result in persistent behavior patterns that can seriously affect your day-to-day function and life. So we are talking about the mind, and we are talking about the stresses that comes to the mind, or we are talking on the abnormalities that are experienced at times on our mind. This is like when the vehicle, for example, when the vehicles have been moving on one direction, and then all of a sudden one starts to behave abnormally, like maybe it's going on a certain direction and then it turns out, or it turns on the other direction abruptly on the way where they are not supposed to be having a U-turn, or you see a vehicle cracking down. So here we are talking about the breaking down of the mind, the abnormalities that comes to our mind, and it makes us not to function well as we are supposed to. So there are causes of psychological disorders which can affect our day-to-day function and life. So the psychological disorders, or the causes of psychological disorders, are chemical imbalances in the brain. We say that our brain are working under the influence of some chemicals that reacts and interacts with the mind, that makes us to behave the way we are. And when we talk about the psychology, we are also talking of the behaviors that are seen based on what is inside of us. So there are chemical imbalances in the brain. There are the childhood experiences. When we were growing up, there are experiences that we went through, and this shapes our mind. They are the heredity factor. Heredity are those that we inherit from our parents, our forefathers. They are the illnesses. At times, an illness may occur in the body of a man or a woman, in the body of a person, and when this illness occurs, it may affect our psychology, our mind in one way or the other. We also have prenatal exposures. Prenatal exposures is when the child was being born, that particular environment where they were exposed to the kind of environment, or to the people who are taking care of this child, the kind of things that the child was exposed into. We have stress. We also have gender plays a role in some, but not all, of psychological disorders. For example, examples of psychological disorders include anxiety, depression, and schizophrenia. What is the definition of anxiety? Anxiety is a feeling of apprehension or fear. When you feel like you fear something, there's something that you don't understand, and also you fear the same thing. The source of this uneasiness is not always known or recognized, which can add to the distress you feel. Anxiety disorders are a group of psychiatric conditions that involve excessive anxiety. Anxiety is the diffuse, vague, unpleasant feeling of apprehension or fear. It is increased arousal accompanied by generalized feelings of fear, which, when such feelings become intense and persistent for a long time, they produce very harmful effects. So There are also types of anxiety disorders. Types of anxiety disorders. We have panic disorder, obsessive compulsive disorder, post-traumatic stress disorder, phobia, generalized anxiety disorders. So let's look at panic disorder. Panic disorder is the abrupt onset of an episode of intense fear or discomfort. Abrupt onset of an episode of intense fear or discomfort, which peaks in approximately 10 minutes and includes at least 4 of the following symptoms. So this is an abrupt onset of an episode of intense fear or discomfort, when something just comes abruptly, but this is a bad feeling, a feeling that is very intense and which brings a lot of fear to a person, and which lasts for at least about 10 minutes. It accompanies itself with the following feelings: a feeling of imminent danger or doom. When someone has experienced an episode of an intense fear, and this intense fear brings about a feeling of imminent danger or doom, the need to escape, palpitations, sweating, trembling, shortness of breath, or shortness of breath, or a smothering feeling. When this person feels like their life is in danger, and it's like they lose a breath of all of a sudden, they have that shortness of breath or that smothering feeling, a feeling of choking, chest pain or discomfort, nausea or abdominal discomfort, dizziness or lightheadedness, a sense of things being unreal or depersonalization, a fear of losing control or going crazy, a fear of dying, tingling sensations, chills or hot flashes. These are just but a few of the signs that sometimes accompany these panic disorders. There are 3 types of panic attacks. One is unexpected, the other one is situational, and we have situationally predisposed. So unexpected is the attack comes out of the blue without warning and for no discernible reason. When somebody is just there and then all of a sudden they feel like an attack, and this person becomes so worried, so anxious, and they don't know what to do. It comes out from the blue. Situational is that one in which an individual always has an attack, for example, upon entering a tunnel. This is when someone enters a place and that place reminds them of a certain experience that had occurred in their lives, maybe sometimes earlier, and then this person starts to feel like they are in a place that is unsafe completely. Situationally predisposed is that situation in which an individual is likely to have a panic attack but does not always have one. It is that time when you find that somebody becomes a lot of apprehended, like apprehension comes all of a sudden, but then it's like this person is not also feeling anything, he's not feeling anything, he's like confusion. An example of this will be an individual who sometimes has attacks while driving. I don't know whether you have ever went to a place and then there is no experience that you've ever experienced about such a thing, but you feel that the place is unsafe to you, and then all of a sudden you feel like you are not in the right place, and you feel like you want to fly, you want to flee, you want to run away, but you don't know any reason, for no apparent reason. Let's look at obsessive compulsive disorder. Obsessive compulsive disorder is characterized by uncontrollable obsessions and compulsions which the sufferer usually recognizes as being excessive or unreasonably. This is an obsession that is uncontrollable, and compulsions which at times is like it's unreasonable, something that is very excessive. Obsessions are recurring thoughts or impulses that are intrusive or inappropriate and cause the sufferer anxiety. These are thoughts that keeps on coming from time to time, and these thoughts are inappropriate and sometimes they cause anxiety. Thoughts about contamination, for example, when an individual fears coming into contact with dirt, germs, or unclean objects. This is a term we call OCD, where you find that somebody fears so much to come into contact with, for example, dirt. If it is somebody who is in the office, you find that at times when you enter their office, they feel unsafe even to shake hands. And where you have sat, they feel that you have left some dirt in that place. So when you get out, they want that place to be thoroughly cleaned. Persistent doubts, for example, whether or not one has turned off the iron or stove, or locked the door or turned on the answering machine. This is when somebody is in doubt. Every time they are not sure of anything, they feel like something has been left unattended and they feel like they want to do that thing. That something needs to be done. Extreme need for orderliness. When someone wants things to be done in an orderly manner, but this also goes to an extreme where they want things to be done. These people are perfectionists. Aggressive impulses or thoughts, for example, being overcome with the urge to yell in a crowd theater where there are people, they just feel like yelling and yelling. It's something that comes abruptly. Compulsions are repetitive behaviors or rituals performed by the obsessive compulsive disorder or OCD sufferer. Performance of these rituals neutralizes the anxiety caused by obsessive thoughts. Relief is only temporary. Like, so for example, the relief that they can do at that particular time maybe is cleaning, repeatedly washing their hands, showering, or constantly cleaning their home. So these are the signs that you can find this person. They are constantly cleaning. Every time they keep on cleaning and cleaning. Or you find them going to a shower every time they feel like they are dirty. Wanafikiria kwamba wamechafuka, saa yote anataka tu kuoga. Or they keep on washing their hands. They greet someone, they go and wash their hands. Every time, every now and then. Then checking. Individuals may check several often or even hundreds of times to make sure that stoves are turned off and doors are locked. Because this person feels that something is made or something has been left unattended. If it is the stove, they go there, they keep on turning off the stove. Even when it is turned off, they want to check every time, every now and then. Repeating. Some repeat a name, phrase, or action over and over. They keep on repeating something. They keep on saying the name. Maybe they keep on saying, say my name. After a while, say my name. After a while, say my name. Then slowness. Some individuals may take an excessive slow and methodological approach to daily activities. They may spend hours organizing and arranging objects. They take many hours trying to organize things, They take a lot of time, long time. Then we have hoarding. Hoarders are unable to throw away useless items such as old newspapers, junk mail, even broken appliances. These are people who fear even to lose information, so they keep on filing information, filing things until their place of work becomes a cluster because they don't put away all the things. If it is in the phone, you find that the messages in their phone have clogged because they don't want to delete any message. In order for OCD to be diagnosed, The obsessions and or compulsions must take up a considerable amount of the sufferer's time, at least 1 hour every day, and interfere with normal routines. So in order for this person to come up to terms with the situation and also to get well from the OCD that they are going through, they need to have time, and this time they need to reschedule their time to make sure that at least a day they do something different, and that something different they are doing is on what they want to change, what they want to see a change in their lives. So exposure to, let's look now to post-traumatic stress disorders, PTSD. Exposure to trauma such as a serious accident, a natural disaster, or criminal assault can result in PTSD. When the aftermath of a traumatic experience interferes with normal functioning, the person may be suffering from post-traumatic stress disorder or PTSD. Symptoms of post-traumatic stress disorders are re-experiencing the event, which can take the form of intrusive thoughts and recollections or recurrent dreams. So symptoms of PTSD is when you find that somebody is asleep and then in their sleep they keep on dreaming like they are in the same thing that happened to them, and it was an experience that was not good to their life. Avoidance behavior, in which the sufferer avoids activities, situations, people, and or conversations which he or she associates with the trauma. So this is where somebody keeps on avoiding everything that may remind them of the traumatic experience that they went through. A general numbness and loss of interest in surroundings. If somebody had gone through a very traumatic experience in their lives and this was within a certain environment, you find that this person try to generalize every environment, and when they get there to a certain environment which resembles the place that caused them that harm, they become numb. They don't feel safe at all, and they want to get out of that place at that particular instance. Then hypersensitivity, including inability to sleep, anxious feelings, overactive startle response, hypervigilance, irritability, and outbursts of anger. Then the other psychological disorder is social phobia or anxiety, at times called social anxiety disorder, also known as social phobia, is an intense fear of social situations. This fear arises when the individual believes that they may be judged, scrutinized, or humiliated by others. So this social phobia is when someone feels unsafe where there are people and they feel that people are judging them wrongly, or they don't want to get to where people are because they feel that these people may look at me in a negative way. Individuals with a social disorder are actually aware of the physical signs of the anxiety and fear that others will notice, judge them, and think poorly of them. In extreme cases, this intense uneasiness can progress into a full-blown panic attack. What are the causes of phobia? Childhood shyness. When someone was growing up and they found that they are shy because they don't want to face people, or depending on the kind of environment that they were brought in, they feel like they are inadequate in certain aspects of personality. Cultural factors which promote feelings of low self-worth. Common anxiety-provoking social situations include public speaking, talking with people in authority, dating and developing close relationships, making a phone call or answering the phone, interviewing or being in a camera. Some people, you find them, they become extreme camera shy. Attending and participating in class, speaking with strangers, meeting new people, eating, drinking, or even writing in a public place, using public bathrooms, driving, shopping. These are just but a few of them. Then we have post-traumatic stress. Post-traumatic stress is the name given to a cluster of symptoms seen in trauma survivors. In cases of major and or repeated traumas, strong reactions may continue for years. So symptoms of post-traumatic stress disorder can include aggressiveness, controlling behavior, interruption of memory and concentration, depression, violent eruptions of rage, substance abuse, disruption in intimate relationships, repeated search for rescue, persistent distrust, repeated failures of self-protection, etc. Major traumatic events include war, sexual abuse, a natural disaster such as floods, accidental disasters such as plane crashes. Those are just but to mention but a few. Female sexual assault functions are, however, considered to be the largest group PTSD sufferers because 1. Lack of decision making, and 2. Very few women are prepared to deal with traumatic stress of rape, and 3. Reactions by the society to the sexually abused, which forces the victims to remain secretive. If somebody had been abused in a community where they feel like men have all the right to intimidate women sexually, you will find that, or you may find that there are some women who are raped repeatedly and they don't speak out because they fear of being scorned by the community or by the society. Excessive and uncontrollably worry about everyday things. These are generalized anxiety disorder. Excessive and uncontrollable worry about everyday things. This constant worry affects daily functioning and can cause physical symptoms. Generalized anxiety disorder can occur with other anxiety disorders, depressive disorders, or substance abuse. So the focus of GAD, or generalized anxiety disorder, worry can shift, usually focusing on issues like job, finances, health of both self and family, but it can also include more mundane issues such as course, car repairs, and being late for appointments. The intensity, duration, and frequency of the worry are disappropriateness to the issue. Common causes of anxiety. There is no one cause for anxiety disorders. Several factors can play a role. There is no one particular cause that you can say this is what causes anxiety, but there are so many that can come on board. For example, we have the genetics, the brain biochemistry, overactive fight or flight response. It can also be caused by too much stress, life circumstances. It can also be caused by personality. People who have low self-esteem and poor coping skills may be more prone. Certain drugs, both recreational and medicinal, can lead to symptoms of anxiety due to either side effects or withdrawal from the drug. In very rare cases, a tumor of the adrenal gland called pheochromocytoma may be the cause of anxiety. What are the symptoms of anxiety? Anxiety is an emotion often accompanied by various physical symptoms, including twitching or trembling, muscle tension, headaches, sweating, dry mouth, difficult swallowing, abdominal pain, which may be the only symptoms of stress, especially in a child. A child may experience some abdominal pain, which is mostly one of the symptoms in children when they are facing anxiety. There are some additional symptoms of anxiety which sometimes accompany anxiety, which may include dizziness, rapid or irregular heart rate, rapid breathing, diarrhea or frequent need to urinate, fatigue. Fatigue is excessive tiredness, irritability, including loss of your temper, sleeping difficulties and nightmares, decreased concentration, sexual problems. Let's look at another psychological disorder. Let's look at depression. Depression is a common mental disorder that presents with depressed mood, loss of interest or pleasure, feelings of guilt or low self-worth, disturbed sleep or appetite, low energy, and poor concentration. Depression is a chronic mental disorder that causes changes in mood, thoughts, behavior, and physical health. It is a common but serious disease that can take away a person's ability to enjoy life and cause decline in capacity to undertake even the simplest daily task. Depression is a serious mental disease that can cause one not to function well in a normal way of functioning. Other than its chronic nature, symptoms associated with these mental disorders are often recurring and life-threatening. We have DSM-5 criteria for diagnosing an individual with a major depressive disorders, and these are sad mood or loss of interest or pleasure, and a term called anhedonia. Anhedonia is a sad mood or loss of interest or loss of pleasure. You don't feel like you want anything. You don't find yourself having that interest that you so used to have. Symptoms are present nearly every day, most of the day, for at least 2 weeks. Symptoms are distinct and more severe than a normative response to significant loss. Plus 4 of the following symptoms, which may accompany these symptoms: sleeping too much or sleeping too little, psychomotor retardation or agitation, poor appetite and weight loss or increased appetite and weight gain, loss of energy, feelings of worthlessness or excessive guilt, difficulty concentrating, thinking or making decisions, or attention. We also have somatic symptoms: recurrent thoughts of death or suicide. That is suicide ideations. You plan an attempt of committing suicide. Persistent depressive disorder. In DSM-5 criteria for persistent depressive disorder is that depressed mood for at least 2 years or 1 year for children or adolescents. This is one of the symptoms that keeps on persisting. You find that this person is depressed for more than a year, for at least 2 years. For a child, somebody is depressed for almost a year, plus maybe poor appetite or overeating, sleeping too much or too little, poor self-esteem, trouble concentrating or making decisions, feeling of hopelessness, symptoms of not clear for more than 2 months at a time. Bipolar disorders are not present at this particular moment. Then we have premenstrual dysphoric disorder. Premenstrual dysphoric disorder is a term where you find that this is feelings that comes with it when individuals are during their menstrual cycle, or before their menstrual cycle, or at times it comes even after, which is post-menstrual disorder, after the menstrual cycle have occurred. You find that there is that feeling, that change of mood, that where this person at times they don't even understand themselves. In most menstrual cycles during the past year, at least 5 of the following symptoms were present in the final week before menses, and improved within a few days of menses onset. This is according to DSM-5 criteria. Affective lability, irritability, depressed mood, hopelessness or self-deprecating thoughts, anxiety. These are the symptoms that accompany this person when they are in this premenstrual dysphoric disorder. Diminished interest in usual activities. You find that this person has got no interest, or interest is falling down. They are failing to have that interest that they so used to have. There is that lack of energy even in doing things. They do things just like because they have to do, but they are not putting all their energy in whatever they are doing. Changes in appetite. There is maybe overeating or food craving. You find this person doesn't eat, or they crave food so much. Sleeping too much or sleeping too little. During that time, you find that this person is oversleeping, or they don't have sleep at all, they lack sleep. Subjective sense of being overwhelmed or out of control. You find that this person anakuwa out of control. They can't control things. They want to yell all over. They lose their temper easily. Physical symptoms such as breast tenderness or swelling of the breast, swelling of the joints or muscle pain, or bloating. This is where you find that the breast becomes so tender. So how does the depression develop? Let's look at development of depression. We have biological theories of depression. These theories assert that the classic neurotransmitters, and neurotransmitters are the chemicals that are in the brain that are so used in information, or sending information from one corner to the other, or interpreting things. Norepinephrine, acetylcholine, and serotonin play important roles in the pathogenesis of depressive illnesses. Other biochemical compounds and peptides may also be involved in the etiology of some forms of mood disorders. So this, in biological theories of depression, is where the chemicals that are so much involved with moods and sending of information in the brain, they are so much involved in this, or which play a very big role in the depressive illnesses of persons with depression. Then we have psychoanalytical theories of depression. The psychosexual phases of development, the structural theory, the broadening of the concepts of orality and anality, the increased understanding of self-esteem, and the deepening insight into the determinants of self-esteem are among the developments of the general psychoanalytic theory, which became reflected in the gradually evolving understanding of depressive illness. So here we are talking of the psychosexual phases of development, where we looked at the structural theory and the broadening of the concepts of orality and anality, where we talk of this is, you remember when we were talking of when children were developing, when they were growing up, and we say that when a child is between 0 to 6 months there, where their attention is on the oral, they depend on the mother, on whatever they are given, they put into the mouth, and then there comes a time when were thinking of the boil, remember. So this gradual development played us a very good role, or a very big role in the psychoanalytical theory, which brings about at times a form of depression in that aspect of development. According to Freud, an individual goes through psychosexual development. If this development is blocked or meets traumatic hurdles, or at any stage, fixation points may develop at the oral, anal, or phallic phase, and ominous consequences may become integrated into the personality structure of the individual. Wakati huyu mtoto anakuwa na anakuja anakuta kuna blockage katika ile area, maybe during the anal stage or during the phallic stage or during the oral stage, unakuta hiyo hali inaleta a form, either anakuwa amepatiwa ile nafasi kwa muda mrefu, imemzidi, ama amekosa vitu ambaye kufanya wakati huo. So unakuta hii inakuja inaleta term ambayo inaitwa fixation, na hii fixation ni ile hali ambayo una crave for, unataka kufanya kitu fulani kwa sababu hukufanya. Unakuta kwamba kuna that urge, you find that there is that urge that wants you to go back to do something that you failed to do, or maybe you overdid that thing and now you find that you feel like doing it again and again, over and over, even when it is not supposed to be there. So this may bring an irritation or irritability in that particular person, and this ndio inakuja inaleta ile hali ya depression. Then we have the third point is psychosocial theories of depression. The psychosocial depression is dysmutual, that is related to imbalances and shifts in moods and social relationships. This is something that brings about the shift in the way we socialize with other people. The etiology of depressive dysfunction disorders is chiefly related to faulty parent-child interaction. So hii ni ile hali ambayo inakuja inatokana na vile ambavyo mzazi na mtoto wanakuwa pamoja, wanahusiana, vile wanakaa pamoja wanapokuwa, how the child and the parent are relating even during the developmental stages, how these parents are taking care of their children, vile unawalea, zile maadili ambayo unawapatia. Hiyo hali inaweza kuwa mzazi anaweza kuwa too strict, ama anaweza kuwa too lenient, alafu mtoto akigrow anakuja anakuta kwamba kuna mambo ambaye sistahili kufanya na pengine aliona kutoka kwao, so anashindwa, anachanganyikiwa hapo katikati what to do. The parents of depressive patients show no affection towards nor interest in their children, except when the children are gravely ill or in a desperate situation. This is where you find that mzazi hana nafasi na mtoto, hashughulikii mtoto wake, mpaka tu pengine mtoto wakati yuko mgonjwa ndio mzazi atashughulika, lakini during other times mtoto anajipanga, anatoka tu, anaenda vile ataenda, anakuja vile atakuja, kama ataoga shauri yake, kama atabadilisha mavazi, kama atakula, it's none of their business. Lakini anakuja tu anakuja tu take care of the child wakati huyu mtoto ako katika pengine ni mgonjwa, ama ako katika hali ya mahitaji fulani ya ambaye ni desperate situation. Then we have cognitive theories, and this is Beck's theory, where we have the negative triad. And negative triad is where the negative views of self, world, and the future. These are pessimistic kind of a theory where you have negativity view of everything, of yourself, of the world, a negativity mindset of the future. We have negative schema, where we are told of the underlying tendencies to see the world negatively. This is where somebody feels like the world has its own flaws, and everything, he sees everything in the world as negative. They even don't understand why they are in this world. They even feel like they should leave this world. We call it negative schema, underlying tendency to see the world negatively. Then we have negative schema, which causes cognitive biases. These are tendencies to process information in negative ways. We have hopelessness theory. Hopelessness theory is that form where the person or individuals feels like there is no hope at all, and they keep on spreading the same hopelessness to others, showing people that it is not worthy even to work hard, because even if you work hard, what will come to you is just the same thing as it happens. These are people who they don't even want to do anything in the world. They don't want to be active. They don't want to put their energy in any work or in any activity, feeling that everything is useless, and that even if you work, whatever you are given in that work is also useless. So they find no meaning in life. Most important trigger of depression is hopelessness. Desirable outcomes will not occur. Person has no ability to change situation. Attributional style. Stable and global situations can cause hopelessness. When the global is stable, when the world is stable, some people can become hopeless because they find no reason of doing anything. And also, when there is in the global things are not also stable, when you find that there is fluctuations of everything here and there are wars, the economy keep on changing every time, you find that people meet or reach a point where they become hopeless in life, and they find that there is nothing that can be done to salvage the situation. We have attributional style. We have rumination theory. Rumination theory is that a specific way of thinking or tendency to repeatedly dwell on sad thoughts. This is where someone keeps on repeating and thinking about the sad things that happened to them. When they remember that particular thing that happened to them, they cry and they cry like a baby. Every time they remember that particular thing, they become sad. And this sadness is that form where it brings them, or it makes them uncomfortable, and they can't do anything. Then this leads us to another PTSD. We look at schizophrenia. Schizophrenia or schizophrenia. Schizophrenia is a group of common major psychosis with a complex syndromal presentation affecting young adults, or showing chronic changes in behavior, perception, thoughts, and emotions, causing a fundamental disorganization in personality and deterioration from previous levels of functioning. This is where a person who was functioning well, they were doing their normal duties, their normal things as usual, and then all of a sudden, things changes all of a sudden, and this person becomes like they are doing a lot of things. They are thinking here, they are overthinking, their mind is going berserk, showing chronic changes in their behaviors and their perceptions and thoughts. It's like they are overthinking and causing fundamental disorganizations in personality. Major disturbances in thoughts, emotions, and behavior, such as disordered thinking, ideas not logically related, faulty perception and attention, lack of emotional expressiveness, such as inappropriate or flat emotions, disturbances in movements or behavior, such as disheveled appearance, which can disrupt interpersonal relationships or diminish capacity to work or live independently, where this person now cannot work alone. They cannot work independently. Somebody needs to be there to give them any attention that they so need. Significantly increased rates of suicide and death. This is where this particular person have this suicide ideation every time they feel like life is not worth, and they feel like they have nothing to live for. So we have said that most of these things comes from, they come into an individual, and at times they go deep into the personality of this person, and so we can zero down into personality disorder so that we may look at this particular individual and the disorders that may arise to a person or to that particular person. So we look at personality disorders, and personality is defined as enduring patterns of thinking, feelings and behaviors and relating to the environment and oneself in a consistent manner and in a various social context. So when you talk of personality, here we are talking of that enduring patterns on when this person is socializing or thinking and feeling and behaving and relating to the environment. The DSM-5 defines personality disorder as an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early childhood adulthood, is stable over time, and leads to distress or impairment. So he said that this is when a child is growing up, and then they develop this PTSD either as a child when they were coming up, and this can cause them not to function well. Personality traits are enduring patterns of perceiving, relating to, and thinking about the environment and oneself that are exhibited in a wide range of social and personal contexts, e.g., shy, suspicious, organized, dramatic, etc. The personality disorders must be distinguished from personality traits that do not reach the threshold for personality disorder. So these are things that are distinguishable, that personality trait that can be distinguished from what is normal. When personality traits are inflexible, maladaptive, and persisting and cause significant functioning impairment or distress to the person, they constitute personality disorders. So here we are saying that when there is that inflexibility, when they are maladaptive are the things that makes these people, yani ni kitu ambaye sio ya kawaida. Mtu sasa ameanza kufanya kitu ambaye hakuwa anafanya, na ni vitu negative, vitu ambazo hazistahili, vitu ambazo mbele ya watu inakuwa ni aibu. So there is a point to note here. We have intern syndrome, which is the tendency of diagnosis oneself while studying any particular disorder. We are told here to overcome the temptations of labeling yourself or even others. You need to overcome that temptations ya kujilabel, ya kujiambia kwamba mimi ni bure, ya kujionyesha ya kwamba wewe haustahili, that ile ya kulabel watu ya kwamba hawa. So you try to overcome that temptations of labeling yourself or even labeling others. People with personality disorders often function well enough on their own and rarely ask or rarely seek treatment. Watu ambao wako na hii personality disorder wakati mwingi wanataka kujifanyia kazi wenyewe. Wengi wao hata waendagi hospitalini, wengine hata waendagi kutafuta counselor. Most of the time you find them working on or functioning well enough on their own. We all exhibit some of the traits that characterize personality disorders at various times and to varying degrees, such as suspiciousness. Sisi wote tunakuwa na some personality disorders, kila mtu wakati mmoja ama wakati mwingine. Wakati mwingine unaangalia watu na suspect, unakuwa na lot of suspicious. Unaangalia hata your wife, unaona this person inaweza kuwa just suspicious. Dependency. At times you find that you get to that point where you depend so much on something or someone. You want to be told what to do, or you fail to make decisions on your own. Sensitivity to rejection. When you find that at times you want to go to a group of people and then you feel like you will be rejected, or you feel that you are being rejected at that particular moment. Which doesn't mean we all have post-traumatic disorders. Wakati mwingi tunakuwa tuna symptoms ya kitu kama hiyo, lakini wakati huo imaanishi kwamba sisi wote tuko na PDS. Researchers believe that PDS are extremes of dimensions of normal personality traits. So wanasema ya kwamba hizi personality disorders wakati mwingi ni zile abnormal traits ambaye zimekuwa nyingi sana, ya kwamba sasa tukikaa chini tuna categorize, tunasema yenyewe hii ni shida, sio ile ambayo una suspect tu once in a while. Personality patterns may not be stable and may vary across situations, and therefore one cannot be certain if a personality disorder is present or not. So at times there can be personality disorders, but you may not be able to identify it or to distinguish. Diagnosis may also be rendered difficult because symptoms of one personality disorder may also be symptoms of other disorders. So the psychological and personality, unapata kwamba these disorders ambazo ziko pale, the symptoms zinakuwa almost the same, so inakuwa vigumu sana kudifferentiate ya kwamba hii symptom ni ya issue gani. So there calls for careful assessment before you come to a conclusion. Personality disorders are chronic and difficult to treat because the traits are inflexible and deeply ingrained, and this makes them tough to modify. So personality disorders ni vitu ambazo zimekolea na wakati mwingine zinakuwa ngumu sana kuzitibu, kwa sababu zingine hata haziwezi zikabadilika tena, na zingine zimeingia ndani sana ya kwamba imekuwa part of that situation. Diagnosis of personality disorders requires an evaluation of the individual's long-term patterns of functioning, and the particular personality features must be evident by early adulthood. Personality traits that define these disorders must also be distinguished from characteristics that emerges in response to specific situational stressors, e.g. the psychotic disorders, depressive and anxiety disorders, extreme stress, substance intoxication, medical conditions, etc. The clinician should assess the stability of personality traits over time and across different situations. Etiology or causes. Causes not well known, but some include genetics, and in the genetics, the malfunctioning genes and other genetic predispositions. Childhood trauma, e.g., have been associated with birth pain disorders. Verbal abuse. Children who experience verbal abuse are 3 times more likely to develop borderline, narcissistic, OCPD, and paranoid PDs in adulthood. So those children, when they were growing up and they were being scolded verbally, watoto wakikua alafu wakakuwa wanatupiwa maneno mabaya, maneno magumu, maneno matusi mabaya,
wakikuwa wadogo, wanapokuwa wakubwa, inasemekana kwamba wao ni zaidi ya wale ambaye walitupiwa maneno wakiwa wadogo, inasemekana kwamba ni mara 3 zaidi yao ya kukua na hiyo hali ya OCPDs, hiyo hali ya borderline ama narcissism. Hawa ni wale watu ambao wanaona kila kitu negative because they were used to be given these negative words and being told that you are good for nothing, and they was called at verbally when they were young. So it is very ni jambo la muhimu sana ya vile tunavyolea, maneno tunayopea watoto wanapokuwa. Any word that you speak to any person, and mostly the young ones, can make a very big difference in their lives during their growth period, because this person can grow up thinking that they were useless, that they can't do anything. High reactivity. This is sensitive children are likely to develop shy, timid or anxious personalities. We have also peer influences, modeling and unintentional reinforcement that at times we give to our children thinking that we are punishing them. Wakati mtoto amekosea, alafu tunakuwa na hii negative motivation where unampatia punishment ama unampiga ama unampatia kazi ngumu, huyo mtoto in the form of thinking that you are making this person to grow, you find that you are not making them to grow in a positive way, lakini unawafanya wanakuwa na ile hali ya kuficha kitu fulani ndani yao. Let's look at general diagnostic features of personality disorders. Enduring pattern of inner experience and behavior that deviates markedly from what is expected in the person's culture, at least in 2 or more areas, i.e. cognition, affectivity, interpersonal functioning, impulse control. So there is the enduring pattern of inner experience and behavior that deviates markedly from what is expected. Hii ni ile hali ambaye unapata kuna tabia sasa ina deviate, ama unatengeneza kitu ambaye ina deviate kutoka kwa ile pattern ambaye hako, unairegesha katika pattern nyingine ambaye unataka kutengeneza. The pattern is inflexible and pervasive across a range of personal and social situations. The pattern causes distress or impairment, that is the social, occupational and other areas in life. The pattern ambaye sasa imekuja imedeviate, unakuta kwamba ina cause social, occupational and other areas katika maisha. The pattern is stable and a long duration. There is the onset of adolescence or early adulthood. The pattern is not attributable to the physiological effects of a substance or other medical condition. The pattern is not better explained as a manifestation or consequence of another mental disorder. Let's look at classification of PDs. The DSM-5 lists 10 specific personality disorders which are divided into 3 groups of clusters. The 3 clusters according to DSM-5 are A, B, and C. Cluster A, ODD and eccentric. Here we have paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. The paranoid personality disorder are patterns of distrust and suspicious such that others' motives are interpreted as malevolent. So the paranoid personality disorder is mahali ambapo kunakuwa na ile kutoamini kabisa na kukuwa suspicious ya kwamba mtu hata akifanya motive fulani, akijaribu kuonyesha, akijaribu kutoa gesture fulani, hiyo gesture inakuwa interpreted kama gesture ambaye haifai, malevolent. Schizoid personality disorder is that patterns of detachment from social relationships and a restricted range of emotional expression. Hii ni ile hali ambayo unapata mtu anakuwa na ile tabia ya kujiondoa kwa watu kabisa. Akiona watu wanakuja hivi, anabadilisha sura, asiongee na watu, asicheke na watu. Wakati mwingine, wakati anakuhitaji, ndiye anakuja kwako na furaha, anakuja kwako kama ana smile, anakuja kwako akikuongelesha vizuri. Lakini wakati akuhitaji, yeye anajitoa, anakaa peke yake. They socially exclude themselves from others people, and they stay alone, and they do things alone, and they want to stay in a secluded place alone, and they only think on themselves and their way of dressing. Hata vile wamevaa, anataka tu kujiangalia tu yeye, na anakonga obsessed. Hata vile amevaa, watu wanamwangalia aje na anavaa design gani. Schizotypal personality disorder. These patterns of acute discomfort in close relationships, cognitive or perceptual distortions, and eccentricities of behavior. So hii schizotypal personality disorder ni ile hali ambaye ni hali very acute discomfort in close relationships. Ni ule mtu akiingia karibu na mahali ya watu ambao wameingiana kabisa na ni watu wa close, anakuwa na ile hali ambaye ni mbaya sana ya kutokaribiana sana na wao. So ni kitu ambaye inamsumbua sana, na ni mtu ambaye tuseme for example kama nyinyi ni rafiki yako, kama anaweza kuambia twende mahali, lakini akifika huko kwa sababu ya kuogopa watu ama watu watamfikiriaje, watu watasema nini, hata anaweza kuacha huko. Ni mtu anaweza kupatia lift, muende naye mahali, mkifika huko akuache. Wewe ujipange vile utakuja, na pengine hata huko anafea. Cluster B, dramatic, emotional and erratic. There are 4 types here in this group: dramatic, emotional and erratic in cluster B. So 1, kuna antisocial personality disorder, pattern of disregard for and violation of the rights of others. So this antisocial personality disorder is that aspect where this person violate the rights of others in a public place. Muko mahali na watu wengine, lakini anataka kuwanyamazisha nyinyi wengine wote. So it is a pattern of disregard for others and violation of the rights of others. Then we have borderline personality disorder. In this borderline personality disorder is a pattern of instability in interpersonal relationships, self-image and affects, and markedly impulsivity. This is that area, na kuna mtu ambaye utampata amecarry all of this. Akona hii borderline personality disorder mahali ambapo akona ile pattern of instability in interpersonal relationships, in self-image and affects. Ni mtu ambaye akikaa karibu na watu wakati mwingi anaweka borders, hataki uvuke mpaka fulani, na equally yeye mwenyewe anaweza saa zingine hata anaweza vuka cross kwa maisha yako, na anaweza kuchezea kidogo, lakini yeye hataki kuchezewa. Then we have histrionic personality disorder. This is a pattern of excessive emotionality and attention seeking. Huyu ni mtu ako na emotions nyingi, amejawa na hisia, na anataka a lot of attention, anataka watu wamwangalie, watu wamjue, watu watambue ya kwamba yuko. We have narcissistic personality disorder. This is a pattern of grandiosity, need for admiration and lack of empathy. Ni mtu anataka watu wamtambue, watu wamwangalie vile amekaa, wanataka watu wamwadmire, lakini yeye mwenyewe hataki kuingia kwa miguu ya watu wengine, hataki kuwafeel, hataki kujua nyinyi mnasikiaje. So ni mtu ambaye anataka tu kukua all over, ajulikane, lakini watu wasimjue. Then the last cluster, the third cluster is cluster C, anxious or fearful. And here we have 3 categories. We have an avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. Avoidant personality disorder. This is a pattern of social inhibition, feelings of inadequacy, and hypersensitivity. Hii ni ule mtu ambaye akienda mahali kuna watu, yeye sasa anataka kujitenga peke yake, anataka kufanya mambo peke yake. Kama ni chakula inapikwa, iletwe tu chakula yake peke yake, ama asikule na watu wengine. Ama kama ni chakula imepikwa, anaweza kuwa pia na ile fear zaidi ya kwamba anaogopa pia anaweza ikewa kitu. So kitu ikiletwa pale kwa meza, kama ni chakula ya kukula, lazima mtu mwingine atest, ama lazima akule na watu, hawezi kula peke yake. So ikiwekwa hapo, anaita wengine, tukuleni hii chakula, na wengine waanze. Na hata mahali ilikuwa imewekwa iangalie yeye, anapindua hiyo upande iangalie wengine. Then we have dependent personality disorder. These are patterns of submissive and clinging behavior related to an excessive need to be taken care of. Huyu ni ule mtu ambaye anajipeana kwa watu na anataka tu kucling mahali kuna watu, hataki kubaki peke yake, na anataka tu saa zote aangaliwe, saa zote afikiriwe. Ni mtu anataka tu kuwa unamuwaza saa yote, unamfikiria atakaaje, atakula aje, atalala wapi, hawezi jifanyia chochote, anataka tu mpaka akuwe anaambiwa. Na hata akikaa mahali usipomwambia, anakaa tu mpaka aambiwe, na anataka kufikiriwa, lakini hataki watu wakae mbali, hataki watu wakae peke yao. Wengine hata wanaogopa giza, so kwa giza anataka tu kuwe na watu, hata akitaka kufanya kitu, afanye kitu ukiwa hapo. Then we have obsessive compulsive personality disorder. It's a pattern of preoccupation with order lines, perfectionism and control. So hawa ni watu ambaye wako na shida, na wao wanataka tu kucontrol watu, na wataki kukaa peke yako. Wanataka kuwe na wewe, lakini ukiwa pale bado wanataka wewe ufanye vile anataka. So hii inatuleta katika subcategories. We have 1, paranoid personality disorder, PPD, paranoid personality disorder. People with this disorder are aloof, emotionally cold, and exhibit unnecessary suspiciousness, hypersensitivity, jealousy, and reluctance to trust others, fear of intimacy. They are people ambaye wakiona watu wako katika uhusiano, wanasema ya kwamba hiyo uhusiano haiendi mbali. Ni watu ambao wana generalize everything. Pengine ni watu walikuwa katika relationship, na kwa ile relationship ikaenda sawa, ikaenda vibaya, wakaumizwa. So wanaenda wakiona watu wengine kwa relationship, wanasema kwamba we wanaume ni wabaya, wanawake ni wabaya. So wana generalize things, alafu hawataki kuingia katika uhusiano, na wakiona wengine wameingia kwa uhusiano, wanakuwa pia na wivu. Wanakuwa na ile hyper suspicious. Kila kitu wana suspicious, wana suspect kwa hali ya juu sana. They assume other people are out to harm or to trick them. When they come close to you, wanaona tu kwamba utawatrick. So hata wakiona mwanamke, msichana na mwanaume, wanaona tu venye huyu msichana atatumiwa vibaya, so wanamwambia wewe chungana. Ama wanaona venye huyu mwanaume atatumiwa vibaya, so ni watu ambaye wako hapo, wana assume kwamba watu wako pale kuwaumiza ama kuwadanganya ama kuwapatia mabaya. They interpret other people's motives to be malevolent. They question their loyalty and trustworthiness. They doubt their spouse's faithfulness and do not confide in others. Distrust interferes with making friends, working with others, and daily interactions. They end up being disliked by others and tend to live isolated lives due to their hypersensitivity to criticism and tendency to project blame on others. These beliefs are extremely resistant to change, and many individuals with this disorder fail to seek treatment because of their mistrust. Hawaamini mtu yote, kwa hivyo hata hawezi hata kwa msaada yeyote. Hawaamini mpaka hata mchungaji, hawaamini mpaka hata counselor, so wanafail hata kwenda kwa msaada. DSM-5 diagnostic criteria for PPD, paranoid personality disorder. A, pervasive distrust and suspiciousness of others beginning by early adulthood and present in a variety of contexts is as indicated by 4 or more of the following: suspicious, without sufficient basis, that others are exploiting, harming, or deceiving the person. 2. Preoccupation with unjustified doubts about the loyalty or trustworthiness of friends or associates. 3. Reluctant to confide in others due to unwarranted fear that the info will be used maliciously against him or her. And 4. Tendency to read hidden demeaning or threatening meanings into being kind remarks or events. 5. Bearing persistent grudges, i.e. is unforgiving of insults, injuries, or minor things. They perceive attacks on his or her character or reputation that are not apparent to others and is quick to react angrily or to counter-attack. 6. Recurrent suspicious without justification regarding the faithfulness of a spouse or sexual partner. Here, it does not occur only during the course of schizophrenia, a bipolar disorder, or depressive disorder with psychotic features, or another psychotic disorder, and is not attributed to the psychological effects of another medical condition. So this one tumeambiwa kwamba haifanani sasa na zile medical conditions zingine ambazo tulikuwa tumezimention pale juu. So the second one is schizoid personality disorder. This disorder is marked by social isolation, emotional coldness, aloofness, and indifferent to others. Affected persons have a long history of impaired social functioning, and they are withdrawn and prefer solitary activities such as watching TV, reading, or taking walks, or staying alone watching YouTube and other things in the social media. They do not enjoy close relationships and find pleasure in very few activities. They can perform well when left alone, for instance, and they are said to make excellent watchmen and security guards. Hawa watu wanaweza kuwa watchman wazuri sana kwa sababu wanataka tu kukaa peke yao. So watafutiwe kazi ya kuchunga tu. Let's look at DSM-5 diagnostic criteria of schizoid personality disorder. A pervasive pattern of detachment from social relationships and a restricted range of expression of emotions in interpersonal settings, beginning by early adulthood and present in various contexts as indicated by 4 or more of the following: lack of desire for or enjoyment of close relationships including family relationships. Hawa ni watu ambaye wanakosa kabisa kukuwa na uhusiano, hata marafiki, hata familia. Almost always chooses solitary activities. Kila wakati wanatafuta tu kazi ya kufanya peke yao bila watu wengine. Little if any interest in sexual experiences with other person. Takes pleasure in few if any activities. They lack close friends or confidants other than first degree relatives. They appear indifferent to the passive or criticism of others. They appear indifferent to the praise or criticism of others. They show emotional coldness, detachment, or flattened affectivity. They does not occur exclusively with schizophrenia or other disorders, but this inakuwa tu unique kivyao. Then the third one ambayo tulisema ni schizotypal personality disorder. These people with this disorder exhibit difficult thoughts and behaviors and have poor interpersonal relationships. Cognitive and perceptual distortions are key features in this disorder, in that they may think that they possess magical thinking abilities or special powers, e.g. they feel they know what others are thinking, which some have recurrent illusions, e.g. they feel that a dead person is watching them. So hawa ni wale watu ambao wanafikiria ya kwamba yule mtu alikufa zamani anawaonanga. So hata akilala anasemanga yule mtu alinia ako hapa, amelala hapa, hata namuona ako hapa. Hata ikaa kwa nyumba anaona kitu kinaendelea, ama anaona damu imejaa kwa nyumba, ama anaona mtu amekuja na amekaa na yeye. ama anaona mlango imefunguliwa. Na hata saa zingine wanaenda to some extent, hata anagonga mlango, anavunja, kwa sababu anaona kuna kitu mbaya kiko pale, ambaye anaifikiria tu ni kitu ambaye inakuja kwa imagination yao. The speech is marked by oddities, e.g. frequent digression, vagueness, etc. They considered odd and bizarre because of the way they think. They relate to others, behave, and even dress. People with schizotypal personality disorder at times develop schizophrenia. DSM-5 diagnosis criteria of schizotypal personality disorder. A pervasive pattern of social and interpersonal deficits marked by acute discomfort with and reduced capacity for close relationships, cognitive or perceptual distortions, and assentivities of behaviors beginning by early adulthood and present in variety of situations, as indicated by 5 or more of the following ideas of reference. This including delusions of reference, odd beliefs or magical thinking that influence behavior and is inconsistent with subcultural norms, e.g. superstitiousness, belief in clairvoyance, telephony or sixth sense. Hii ni ile hali ambaye mtu anafika mahali ambapo anaona kama anaona vitu, ni kama anaona mbingu, ni kama ana connect. Hawa ni wale watu wakiingia kwa kiroho, unakuta ya kwamba wanakanga design fulani waweze kushika area, waweze kushika laini, alafu wanaonanga kabisa ya kwamba wamefika katika ulimwengu wa kiroho na wameshika laini, na wanakuambia kwamba wanaona kila kitu. It is a disorder. Unusual perceptual experiences including bodily illusions. Ni wale watu ambao wako na hali ya kufikiria na kuwaza mambo mpaka mahali ambapo sasa wao wenyewe hata kwa mwili yao wanahisi kabisa ya kwamba wametoka kwa hii mwili wameingia kwa mwili mwingine. Odd thinking and speech, e.g. vague, they over elaborate things. Wanaingia katika ile hali ambayo sasa si ile ya kawaida. Suspiciousness or paranoid ideation, inappropriate or constricted affect, behavior or apparent that is odd, eccentric or peculiar, lack of close friends or confidence other than first degree relatives, excessive social anxieties associated with paranoid fears rather than negative judgments about self. They does not occur exclusively with schizophrenia or another disorder. Number 4, antisocial personality disorder, APD, characterized by chronic antisocial behavior patterns, e.g. failure to conform to social or legal rules, a lack of anxiety or guilt, irresponsible behaviors, and lack of remorse. They show little guilt for their wrongdoing and have fleeting, superficial relationships with others. Engaging in delinquent or adult criminal behavior is not sufficient to diagnose antisocial personality disorder. Although some criminal meet some of the criteria for APD, not all criminals have the disorder. Antisocial behavior is usually lifelong with onset in childhood or early adolescence. DSM-5 diagnosis criteria of APD. A pervasive pattern of disregard for and violation of the rights of others, including occurring since age 15, as indicated by 3 or more of the following: failure to conform to social norms with respect to lawful behaviors and evidenced by repeatedly breaking the law; deceitfulness, including lying, use of aliases, or conning others for profit or for pleasure; impulsivity or failure to plan ahead; irritability or aggressiveness; as indicated by frequent fights or assaults. Reckless disregard for safety of self or others, consistent irresponsibility with employment or paying bills, lack of remorse at harming others, and the individual is at least 18 years old. Evidence of conduct disorder with onset before age 15 years. It does not occur exclusively during the course of schizophrenia or bipolar disorder. Let's look at borderline personality disorder, BPD. It is characterized by intense infatuation in mood, self-image, and interpersonal relationships. Affected people are impulsive. They have chronic feelings of emptiness, form intense and unstable interpersonal relationships. E.g., they may be friendly today and hostile the next day. They change from angry to depressed within a short time. These are people with borderline personality disorder. They are more likely to attempt and commit suicide than the general population. They engage in self-mutilation, e.g., cutting, burning oneself with cigarettes, etc. Hawa ni wale watu ambao sasa ndio unakutaga wamejitattoo everywhere because they enjoy the mutilation. Wana enjoy inflicting pain on themselves. DSM-5 criteria, diagnostic criteria of BPD: a pervasive pattern of instability of interpersonal relationships, self-image and affects, unmarked impulsivity, beginning by early adulthood and present in a variety of contexts as indicated by 5 or more of the following. 1. Frantic efforts to avoid real or imagined abandonment. A pattern of unstable and intense personal relationships characterized by alternating between extremes of ideation, that is, portray as ideal, perfect, and the evaluation, portray a worthless without value. Identity disturbance, persistence, instability, self-image or sense of self. Recurrent suicide behavior, gestures or threats or self-mutilation. Impulsive in at least 2 areas that are personally self-imaging, e.g., spending, sex, substance abuse, reckless driving, binge eating. Affective instability due to reactivity of mood, e.g., irritability or anxiety, usually lasting a few hours and rarely more than a few days. Chronic feelings of emptiness. Inappropriate, intense, eager, or difficulty controlling. Anger. 6. Histrionic personality disorder. Engage in exaggerated expression emotions, e.g., crying uncontrollably during a sad movie, hugging someone they have just met tightly, and attention-seeking behaviors. Huyu ni watu wenye wako na HPD, histrionic personality disorder. Overly dramatic and seem like they are acting. Flashly, showily, and flirtation, and exhibit superficially charm and warmth. Shallow and egocentric or self-centered. Over-concerned with their appearance and looks. They often manipulate others through emotional crises, charms, sex, seductiveness, or complaining. DSM-5 diagnostic criteria of HPD. A pervasive pattern of excessive emotionality and attention. Attention seeking beginning by early adulthood and present in various contexts as indicated by 5 or more of the following. Uncomfortable in a situation in which he or she is not the center of attention. Huyu mali anapata kwamba yeye ni kama hana attention pale, hakuna watu wanamtambua, anakuwa comfortable in that situation. Interaction with others often characterized by inappropriate, sexually seductive or provocative behavior. They display rapidly shifting and shallow expressions of emotions. Styles of speech is excessively impressionistic. That is, they are based on impression rather than on facts or reasoning, and lacking in detail. Consistently uses physical appearance to draw attention to self. They have self-dramatization, theatrical and exaggerated expression of emotion. This group is suggestible, i.e., easily influenced by others or circumstances. They consider relationships to be more intimate than they usually are. And that is all that we learned today on personality disorders. That was about personality disorders. And now, in a very short while, I would like us to look at psychological therapists. Psychological therapists, so as to finish with these psychological disorders. Because we have said that psychological disorders are the things that affect the mind, they affect the thinking capacity of the individuals. And here in the psychological disorders, the psychological therapist, we have four major types of the therapists. Therapists are caregivers, or those who are concerned with the psychological disorders that we have just talked about, and the ones who came with the theories and what need to be done. And here we have psychodynamic, which is, this will look at, psychodynamic will look at your background. It will give you a background of all things. So we have humanistic, behavior, cognitive, and then we'll look at the group. So in the introduction part of it is that the most of the above psychotherapists have their basis on the theories of personality development. For example, psychodynamic theory is based on Freud's psychoanalytic theory. Humanistic theory is founded in Rogers' person-centered theory. Behavior and social learning theory of Bandura and Skinner stimulates development of behavior therapy. So it is important to note that most therapists today use they use electric therapy. Electric therapy is where they use a variety of approaches depending on the needs of the client and experience of the counselor. So the electric, where many people today, many therapists today, many counselors, many psychologists today, they use the electric theory, where they combine different theories all together in one setup. So they try to synergize, to bring that synergy from different theories in order to suit the particular kind of situation that they are in order to help those individuals to come out of the situation that they have in themselves. So we have psychodynamic therapist. Here, they stress the importance of the unconscious mind and extensive interpretation by therapists. Important role played by early childhood experience is some of the concern, and some of disorders is anxiety that arises when the unconscious has unacceptable emotions, desire attempt to break into a person's consciousness. So in this psychodynamic therapies, we are told here that negative emotions, wishes, and desires are suppressed in the unconscious mind, and only what is acceptable is allowed to surface in the conscious part of the mind. The modern or contemporary psychodynamic therapist emphasizes development of self in social context, i.e., early attachment relationships with attachment figures. So the goals The goal for psychodynamic therapists is to bring shameful thoughts, emotions, and desires and conflicts into consciousness to facilitate a healthy understanding of their implications. So they encourage free associations. The therapist interprets what is said freely in the dream analysis while taking care of any transference feelings and resistance. So here is where the therapist concentrates. The therapist interprets what is said freely, especially in the dream analysis. Getting client to identify and seek out appropriate relationship with others. Then another goal here is develop more appropriate appraisal of relationships. The counselor-client relationship demonstrate empathy and understanding. We have humanistic therapy. In humanistic therapy, encourages personal growth and self-awareness. Here, they encourages individuals to develop accurate perceptions and emphasizes conscious thoughts. And here, the present is more important than the past. The present, the life of today, where they are right now, is more important than the past. So they tell their people not to dwell, or their client not to dwell on the past, but to look at life at the present. Here, humanistic is where most cases you will find them using the mindful techniques or the mindfulness. Growth and fulfillment are the key as opposed to curing of the problem. Humanistic therapists, e.g. Rogers, believe that human beings are basically good and have the ability to direct their lives towards desired goals. 6 conditions are however desirable, and they are: 1. A warm, acceptable environment. 2. Unconditional positive regard. 3. Empathic understanding. 4. Genuineness. 5. Counselor is congruent. Congruent is knowledgeable. 6. Counselor is incongruent or unknowledgeable. This is where they believe that you learn from experience. Behavior therapy. Behavior therapists believe that many emotional and behavior problems are caused by inappropriate response. They focus on change of behavior rather than gaining insights and self-awareness, and they use principles of learning to remove abnormal or maladaptive behavior. Here they say that behavior is learned, unlearned, and relearned. Based on the classical conditioning, they mainly use the technique of systematic desensitization. They also operant conditioning, which is use of reinforcement, where you give rewards for appropriate behavior and punishment, or you remove privileges. The behavior therapy, as we said, their goals is to replace unacceptable responses with acceptable adaptive ones, and behavior therapists are especially useful with young children since they focus on behavior change and not changing thoughts or gaining insights. They use structured training sessions that require individuals to practice prescribed exercises. Then we have cognitive therapists. They aim at helping individuals adapt through modifications of thoughts and behavior. The goal is to change misconception, to strengthen coping skills, to increase self-control, and encourage constructive self-reflection. They emphasize that abnormal behavior is a result of faulty and irrational thinking, not very concerned about the origin of the problem. So their concern is to emphasize on the abnormal behavior, that abnormal behavior is as a result of faulty and irrational thinking. So they engage in conversational format. Then we have the group therapists. They propose save time which reduce costs, and clients are seen within the context of relationships, i.e. important groups like family, peers, marriages, etc. So in the group therapists, their work is to, they put people together according to the relationships that they have. The features of a group include: 1. Individuals receive information about one's problem from leader of the group or other members. So here the individual receive information about this person from a group, and then they categorize them to that group. 2. At the group level, each member feels that all sufferers or universalities, where this is whereby when people are categorized into a group, every member feels that we are all sufferers, so we identify each other because we go through the same issues. Support and encouragement from other group members is also received here, and therapy groups like a family where the leader performs the role of a parent and other members like other siblings. The reliance on others in the group for feedback, which one would believe is very key, and the group serves as a training ground to practice what is learned. Effectiveness of therapies. Therapy effectiveness depends on use of appropriate therapeutic approach by the therapists, knowledge on the part of the therapists, observance of ethics by the therapists, then therapist-client relationship. Therapist bias in cases where therapists do not understand ethnicity, religious, genders, and cultural differences. So when a therapist fails to understand the dynamics in terms of the cultures, in terms of the religions, in terms of genders, and just to mention but a few, that may bring that bias where the client may feel that this person was biased to me, he was so hard on me, he judged me, and we say that counseling is non-judgmental. So it also depends on the characters of the client, where the client can be low motivation or tolerance of anxiety. The character of the therapist, is he aggressiveness, dominant, impatient therapist? It can also depend on the competence of the therapist. And that, with those are many, we have come to our course for today on psychological disorders.